Hello, my name is Mrs. Tench. Today we are going to be discussing trauma and stress-related disorders. The last few lessons we've been discussing the concepts of mental health and mental illness nursing. Now we're going to be discussing individual diagnoses, disorders that we will be discussing in class when we're doing our synchronized time, and you'll see these diagnoses when you are in the practicum setting. So historically, what is post-traumatic stress disorder? This has been around for a long time. We used to call it shell shock, battle fatigue, post-traumatic neurosis, and in the DSM-3 in 1980, it first appeared as a diagnosis of a mental illness. So, what's the DSM-3? It's a diagnostic and statistical manual of mental illness. I was working under the DSM-3. The diagnosis manual gives the psychiatrist characteristics of the disorder, and it helps in diagnosing disorders. Remember, with mental health disorders, there's no lab test that we really can do to say, this is what you have. We have to go by characteristics and presenting factors. So now we're utilizing the DSM-5. So that's how long this has been in existence. So this is an interesting statistic. More than half of all individuals will experience a traumatic event in their life, but less than 10% will develop post-traumatic stress disorder. Why is that? Why doesn't everybody develop it? I use this as an example. Two people can witness a car accident with multi-casualties. One of the witnesses will go to work, and the other witness has severe anxiety and develops post-traumatic stress disorder. So why is that? We're going to talk about different theories because we don't know. We think there's a genetic component and an environmental component with this diagnosis. All right. Traumatic event is described as one that is outside the range of unusual human experience. Okay? And it's more common in women than in men. So that's what we do know statistically. Individuals have difficulty with stress reaction to more normal events may be diagnosed with adjustment disorder. Okay, we're going to be talking about adjustment disorder also because that falls into that traumatic diagnosis, stress diagnosis. Adjustment disorder are quite common and can occur at any age. Now this did not come out. The DSM-5 had adjustment disorder. So it's relatively new. I've been seeing it more and more diagnosed in the psychiatric setting. So what is post-traumatic stress disorder? It's a reaction to that extreme trauma, which is likely to cause pervasive distress to anyone, almost anyone. Distress to almost anyone, such as natural or man-made disasters, combat, serious accidents, witnessing violence, death of somebody. You witness a death, being the victim of torture, terrorism, rape, or other crimes. So that's the definition of post-traumatic stress disorder. What are some characteristics? Some of these are red. I would remember those. They're all important, but re-experience the traumatic event flashbacks, intrusive recollection or nightmares, anger, aggression, substance use disorder, survival guilt, amnesia. This numbing of response is very interesting to consider because you can't sometimes see the distress. They are very good at masking their symptoms. The internal struggle is what we see. They have problems with relationships. Symptoms may begin within the first 3 months after the trauma, or there may be a delay of several months or even years. So that's important to consider. Remember, when we're looking at the DSM-5 manual and looking at characteristics for diagnosis, this is typically one that would put them in this category of developing post-traumatic, of being a diagnosis of post-traumatic stress disorder. Then there's something that's relatively new. In the DSM-5, it appeared as acute stress disorder, because when you're looking at data and statistics, diagnosis, you see trends, and you realize there is a percentage of the population, they have the symptoms of post-traumatic stress disorder, but there's differences. It's time limited, up to 1 month following the trauma. If it lasts longer than a month, then we're going to call it post-traumatic stress disorder. So the characteristics we talked about a couple of slides ago, if they go away in a month, then it's acute stress disorder. So now let's talk about some theories. The psychosocial theory seeks to explain why individuals exposed to massive trauma develop post-traumatic stress disorder. Variables include characteristics related to the traumatic experience, the individual, and the recovery environment. Very important to remember. Then there's learned behavior theories. Negative reinforcement leads to the reduction in an adverse experience, thereby reinforcing, resulting in repetition of the behavior. Avoidance behavior, psychic numbing. So those are learned. That's a learned theory. I'm a cognitive person. I believe there's a component to each of these theories have something to be considered, but I'm a cognitive person, and since I'm developing the test, I'm going to discuss the cognitive theory. A person is vulnerable to post-traumatic stress disorder when fundamental beliefs are invalidated by experiencing trauma that cannot be comprehended, and when a sense of helplessness and hopelessness prevails. And why do I believe in this cognitive theory? Well, I said I was a cognitive person. I know we are what we think, and we have control over our thoughts, and our thoughts drive behavior. And so I hear hopelessness and helplessness when I'm talking to my patients in the psychiatric setting. It's a common theme, and that's where I get my foundational beliefs in theory. There's biological aspects, of course. Remember I said there's a genetic component. Our brains react when our sympathetic nervous system is activated during this when this event occurs. And in our autonomic nervous system, we have the sympathetic, we have the parasympathetic. If you're unsure about this system, please refresh yourself. This is very important, how we respond to our biological response. And we also have a deregulation of our pain receptors and our neuroreceptors and our neuroendocrine system that changes the chemistry of our brain. And the longer that we have these catecholamines and cortisol levels, our brain structures actually change. And we're going to be talking more about that as we continue to discuss diagnosis as mental illness. All right, so what's some nursing interventions? What's some nursing diagnosis? In your textbook, it does such a good job of giving you plans of care. And the nursing diagnosis that they have fully developed with, as evidenced by, related to, interventions, evaluation of outcomes, they're in your textbook. So post-traumatic syndrome is a nursing diagnosis, okay? These are different than medical diagnosis. These are psychiatric nursing diagnosis, okay? Complicated grieving, risk-prone health behavior. So those are 3 nursing diagnoses that can be considered when you assess your patient and find some of these characteristics that fit into these nursing diagnoses. So when you're developing your plan of care for your concept map and you're working on your case studies, that's going to be in homework 3. You can use your textbooks as a very wonderful resource. So what's outcome? The client can acknowledge the trauma and the impact on his or her life. They can demonstrate adaptive coping strategies. They have realistic goals for the future. Remember, our relationships are goal-oriented. Recovery is a goal-oriented process, so we want them to develop goals for their future and interventions and how they're going to reach their goals. And has worked through their feeling of survivor guilt, if that's part of this trauma. Attended sports groups of individuals recovering from similar traumatic experiences. That's very important. That peer support that we talked about earlier for the recovery process verbalizes desire to put traumas in the past and progress with their life. So how do we implement this? We want them to be safe. We want to decrease maladaptive symptoms. We want them to have coping strategies that are adaptive in nature. And we want them to go through the grieving process because they've lost their mental health. That is very important to remember. When people have lost their mental health, it's a loss that needs to be grieved. And how do we evaluate if this is our plan of care is effective? Can the client discuss the traumatic event without experience of panic anxiety? Has the client learn new adaptive coping strategies for assistance with recovery? Very good, very good. So now we're going to talk about another stress-related disorder. It's an adjustment disorder. This is relatively new and in the DSM-5, and I see this diagnosed more and more in the psychiatric setting. It's characterized by a maladaptive reaction to an intense stressor or stressors that result in the development of clinical significant emotional or behavioral symptoms, and the symptoms occur within 3 months of the stress and last no longer than 6 months. So it's a short-term disorder, but it's very challenging nonetheless, except if it's a bereavement issue, then that's different. Okay. There are different types of adjustment disorders. You can have adjustment disorders with mood disorders. Okay, so you have an adjustment disorder and a mood disorder. You have an adjustment disorder with anxiety. You have an adjustment disorder with mixed anxiety and depressive moods. You have adjustment disorder with a disturbance of conduct. I saw a lot of that at Cumberland before we really had a diagnosis for that. We were just calling them conduct disorders when I think, in fact, there may have been some that were just adjustment disorders or oppositional defiant disorders, depending on their age. With mixed disturbance of emotional and conduct and related to bereavement, or we just don't know, unspecified. Interesting. All right, so why do people develop adjustment disorders? Well, they're genetic, of course. Vulnerability related to neurocognitive or intellectual developmental disorders. So cognitive functioning can be a factor. Psychosocial theories, child trauma, birth characteristics, where they are in the birth order, developmental stage and timing of the stress, very important. Oh my gosh, I can't emphasize the importance of that. That's why the Erikson's personality development theory is so important, because if your trauma or your adjustment occurred, let's say you were 7, then it's going to be different than if it occurred when you were 15. Okay, so that's why we talk about the developmental stages and dysfunctional grieving process, and if they have support with their family, in the community. All right, so then we have that transactional model of stress adaptation, different types of stressors, and the nursing diagnoses are very common to what we saw with our trauma, and the outcomes are very common. We want them to reach goals and be able to cope and things of that nature. And the treatment modalities are very specific to the person, please refer to your textbook so we can talk about those diagnoses in our